Yes. Please start.
Yeah, good afternoon, everybody. This is Dr. Banik Chaudhary. I'll be presenting the
Vinay, please share
SLOs.
screen again.
Hello.
Yes. We saw your screen and then it went back.
Endocrine now?
Yes.
Yes, endocrine. Yeah, SLOs on endocrine pathology.
Yeah. And I would like to introduce Dr. Banik Chaudhary. I know him very well. He is from Mumbai, who has done MD pathology from Grant Medical College, Mumbai. Nice to hear from you, Dr. Barnik. Now he is an associate professor.
Thank you, madam.
A very dynamic person from Department of Pathology. He is now at Calcutta College of Medicine and JNM Hospital, West Bengal. He has obtained a Zeller Fellow in Lung Pathology from Mayo Clinic, USA. And he's also a very national coordinator for IAPM PG quiz, undergraduate students PG quiz. Sure.
Thank you, madam. Thank you for the kind words.
No.
Dr. Vinay, please share screen.
Yeah, share screen. Yeah, show my screen. Be here.
Yes.
Slideshow.
So, in endocrine pathology, first we'll see what are the competencies that MCI has given. There are 9. Okay. So along with me, Dr. Tamil Selvi has also contributed in this effort. I want to thank her from the bottom of my heart, and I'll start with that. Okay. So there are 9 competencies, 4 of which are core and 5 of which are non-core. The first competency is enumerate, classify, and describe the etiology, pathogenesis, pathology, and iodine deficiency of thyroid swellings. Second one is describe the etiology, cause, iodine dependency, pathogenesis, manifestations, lab and imaging features, and course of a thyrotoxicosis. Third one is describe the etiology, pathogenesis, manifestations, lab and imaging features, and course of thyrotoxicosis or hypothyroidism. So there is an overlap between PA 32.2 and PA 32.3. I'll come to that. Then fourth is PA 32.4 is classify and describe the epidemiology, etiology, pathogenesis, pathology, clinical lab features, complications, and progression of diabetes mellitus. This is the most important one, and I'll be dealing with this in detail as we go on. Next comes the 5 non-core competencies. Describe the etiology, genetics, pathogenesis, manifestations, lab and morphologic features of hyperparathyroidism. Next, PA 32.6 is describe the etiology, pathogenesis, manifestations, lab and morphologic features, complications and metastasis of pancreatic cancer. PA 32.7 describe the etiology, pathogenesis, manifestations, lab, morphologic features, complications of adrenal insufficiency. PA 32.8 describe the etiology, pathogenesis, manifestations, lab, morphologic features, complications of Cushing syndrome. So 32.7, 32.8 dealing with hypo and hyperadrenalism. There's an overlap, and we'll go about it similarly. PA 32.9 describe the etiology, pathogenesis, manifestations, lab and morphologic features of adrenal neoplasms. So that makes the 9 competencies that we are to discuss today. Next, going on to the first 1, PA 32.1, enumerate, classify, and describe the etiology, pathogenesis, pathology, and dependency of thyroid swellings. So I have divided this into 4 SLOs. So to classify the thyroid swellings, to enumerate the etiology of thyroid swellings, to discuss pathogenesis and pathology of thyroid swellings, and finally to list the clinical features and list the lab diagnosis of thyroid swellings. All of them are in knowledge domain, and know-how is the highest level. And for this, self-directed learning, small group discussion, case-based discussion should be sufficient, and this should be we have felt should be centered around a DOAP session with gross specimens of thyroid specimens to guide the students with. And assessment methods would be modified essay type questions, small short answer questions, multiple choice questions, Viva VOC, and OSPI. And vertical integration has been advised with human anatomy, physiology, general medicine, and general surgery departments. So we can have an integrated session also if time permits with these departments. So next, going on to the second competency, which we have merged with the third competency. So let's go with this. Describe the etiology, cause, dependency, pathogenesis, manifestations, lab and imaging features, and course of thyrotoxicosis. Here the SLOs are to enumerate the etiology of thyrotoxicosis, to discuss the pathogenesis and pathology of thyrotoxicosis, to list the clinical manifestations of thyrotoxicosis, and to list lab and imaging features of thyrotoxicosis. Knowledge domain, all of these are knowledge domain, and know-how is the highest level. And as I mentioned, this is also a core competency. And here, small group discussion with case-based discussion may be done, and initially bit of self-directed learning can be provided to the students as they have already done this part in their physiology classes. So that can be a kind of a recap of their physiology topic that they have covered. Also, vertical integration with physiology and general medicine can be provided if time permits. Assessment methods are MEQ, SAQ, MCQ, and Viva VOC. So we are not taking any lectures per se, just a small group discussion and case-based discussion can be done. Coming to the third competency, describe the etiology, pathogenesis, manifestations, lab and imaging features, and course of thyrotoxicosis or hypothyroidism. Here, the SLOs would be to enumerate the etiology of hypothyroidism, to discuss the pathogenesis of hypothyroidism, to list the manifestations and course of hypothyroidism, and to list the lab and imaging features of hypothyroidism. So this is complementary to the previous competency 32.2. So we have merged it. So a single session of a small group discussion can be taken to cover both these competencies. And the teaching learning methods will be similar. So will be the assessment methods, and also vertical integration with physiology and general medicine will also be common. So these two competencies will be merged into one for one teaching learning session. Next, coming to the most important one, which is on diabetes mellitus. The competency mentioned is to classify and describe the epidemiology, etiology, pathogenesis, pathology, clinical lab features, complications, and progression of diabetes mellitus. This we are divided into 8 SLOs. Actually, we can go on and on for finding SLOs on diabetes mellitus. We have just restricted ourselves to 8. To classify diabetes mellitus, to describe the epidemiology of diabetes mellitus, to enumerate the etiology of diabetes mellitus, to discuss the pathogenesis and pathology of diabetes mellitus, to list the clinical and lab features of diabetes mellitus with diagnostic criteria, and to list the complications of diabetes mellitus, and finally to end it to discuss in detail about gestational diabetes mellitus.
Hello, can you hear me? I can't hear you, Dr. Barnik.
Barnik was offline. He has just come back.
Okay.
Self-muted.
Yeah,
Yes.
I've unmuted myself. The teaching learning methods used out here be SDL, small group discussion, case-based discussion, lectures, and videos as required. Assessment methods may be MEQ, SAQ, MCQ, and Viva Voce. And vertical integration with physiology and general medicine departments can be done, and we have also suggested an integrated teaching symposium which can deal with multidisciplinary or interdisciplinary integration, as Dr. Prasad had mentioned in the last lecture. So we kept 2 hours lecture for this very important competency, and along with that, one integrated symposium for this. Next, please. Yeah. So this is the multidisciplinary or interdisciplinary integration that we have suggested. 1.5 hour symposium, starting from anatomy department, either the faculty or it can be a student symposium also, but we prefer initially to go with only faculties. So anatomy department will discuss microstructure of islet cells. Physiology department will discuss the glucose homeostasis by insulin. Biochemistry department will cover the WHO diagnostic criteria of diabetes mellitus. Pathology department will cover classification of diabetes mellitus, etiopathogenesis, pathophysiology, and complications of diabetes mellitus. And pharmacology department will cover oral hypo agents and insulins. Community medicine department will deal with lifestyle changes for preventing diabetes mellitus in family members of known diabetic patients. Gynecology and obstetrics department will cover gestational diabetes mellitus. Medicine department will deal with monitoring and treatment of patients for complications. And finally, there will be this summary session with question answers from the students to the faculties concerned. So this is how we have envisaged an integration of all the departments, all the disciplines in this very important topic of diabetes mellitus. Any questions? If anybody has, I can take it now or later as you all want. Okay, coming to the 5 non-core competencies. They are the one on hyperparathyroidism, describe the etiology, genetics. Yes, sir.
There is one question by Dr. Astitwa Devroy. How can highest
Yes.
level I'll just unmute him. Dr. Devroy, can you unmute yourself?
Yes.
Yes, sir.
Yes, your question?
Yes, sir. Actually, Dr. Barnik, I wanted to know how can this enumerate and classify? You're saying that the highest level is know-how. So how can this enumerate, classify? How can this be know-how? I mean, according to me, this should only be know.
No, okay, fine. Actually, know-how, I've kept it as the rationale for classification, how diabetes is being classified. That is the monogenic forms of diabetes, which genes are involved. So that is the rationale how it is being classified. So they would be knowing how that diabetes mellitus is being classified by WHO. So that is why I've kept it as know-how.
Now, suppose you're
And
listing the
enumeration.
clinical. Suppose you're listing the clinical manifestations. So I'm just enlisting the manifestations, right? So
Yeah.
So in that case, I mean, would it be know-how?
Obviously, you would have to do a bit of a clinical pathology correlation at the back of your mind to understand why there is polyuria occurring, why there is polyphagia occurring. So just knowing the listing is not sufficient. Why it is occurring, if the students are not aware of that, then it will just be rote learning, and we don't want that. Do we?
Dr. Barney, if you
Yes.
increase the level of that verbs, these verbs are at the no level, knowledge level, basic level, recall. So if you change the category of your verbs, definitely you can take it to a higher level. Actually, it is all the play of verbs and what you.
Yeah. Sure.
Thank
Action verbs.
you.
We can change the action verbs. Yes. Accepted. Yeah. Hello, sir.
Thank you so much.
Hello. Dr. Lanjevar speaking.
Lanjevar, sir. Good afternoon.
The first swelling on thyroid, first competency. You have included surgery in integration.
Right, sir.
Can we add ENT department now?
Sure, sure.
Surgery, they are handled by thyroid surgery by ENT department as a specialized branch. Just add that. Rest of the thing was fine.
Thank you, sir, for the suggestion. Okay, so going on with this competency, PA 32.5, describe the etiology, genetics, pathogenesis, manifestations, lab, and morphologic features of hyperparathyroidism. The first one, SLO, is enumerate the etiology, and including genetic associations of hyperparathyroidism. To discuss the pathogenesis and morphology of hyperparathyroidism. Third, to list the clinical manifestations of hyperparathyroidism, and to list the lab features of hyperparathyroidism. It's all in the knowledge domain. This know-how. Yes, we can deal with the action verbs later. Thanks for the suggestion, Dr. Achitawa. And since this is a non-core competency, we have not taken any lectures for this, just SDL and handouts for this particular topic. We have considered it sufficient, so that there is no wasting of time, of precious time that we have for this lecture in pathology. Just 80 hours is a very scarce commodity. Assessment methods, we have kept MEQ, SEQ, MCQ, and Viva Voce. And vertical integration suggested is with physiology and general medicine, if time permits. PA 32.6, next one, please. Okay, so PA 32.6 deals with pancreatic cancer. Pancreatic cancer mostly is of the exocrine pancreas. So we were actually a bit confused why it has been included in this endocrine pathology. So if possible, if it can be included in exocrine pancreas lesion in the GI, it can be done. Otherwise, we'll do with one lecture and case-based discussion and this, and just a small handout can be given for the endocrine tumors of pancreas like insulinoma, glucagonoma, and VIPoma. So the SLOs for this particular competency are to enumerate the etiology of pancreatic cancer, to discuss the pathogenesis of morphologic features of pancreatic cancer, to list the clinical manifestations and spread of pancreatic cancer, and to list the lab features and of pancreatic cancer, and to list the complications of the same. This is a non-core competency, but since there is increasing importance of pancreatic cancer worldwide and also in India, so we felt this needs a bit of discussion as a lecture, either in here or in the GI path classes. Vertical integration with general surgery has been advised, and assessment methods would be MEQ, SAQ, MCQ, and viva voce. Next, please. This PA 32.7 and PA 32.8 have been merged, as they both deal with the functional aspects of adrenal gland. PA 32.7 deals with describe the etiology, pathogenesis, manifestations, lab morphologic features, complications of adrenal insufficiency. The SLOs which have been derived to enumerate the etiology of adrenal insufficiency, to discuss the pathogenesis and morphologic features of adrenal insufficiency, to list the clinical manifestations of adrenal insufficiency, to list the lab features of adrenal insufficiency, and to list the complications of adrenal insufficiency. So this is a knowledge domain topic, non-core competency. So no lectures have been yet for this. SDL, small group discussion, and case-based discussion should be adequate. And assessment method would be MEQ, SAQ, MCQ, and viva voce. Vertical integration would be with physiology and general medicine if time permits. Next, PA 32.8 to describe the etiology, pathogenesis, manifestations, lab morphologic features, complications of Cushing syndrome. So after hypoadrenalism, we have hyperadrenalism, and the SLOs which are derived are to enumerate the etiology of Cushing syndrome, to discuss the pathogenesis of and morphologic features of Cushing syndrome, to list the clinical manifestations of Cushing syndrome, to list the lab features of Cushing syndrome, and to list the complications of the same. Again, knowledge domain, and this is a non-core competency, and so we, like PA 32.7, we have SDL, small group discussion, and case-based discussion for this, and this will be merged. So only one session of small group discussion will deal with both PA 32.7 and PA 32.8. Assessment methods will also be same: MEQ, SAQ, MCQ, and viva voce. And vertical integration with physiology and general medicine will be done.
Dr. Barnik, I want to say something.
This. Yes, sir. Yes, madam.
Here about this Cushing syndrome, I agree, as it is a non-core competency, so they should know what are the features, etc. Here you can add one more other etiology of Cushing's, because it is also a part of paraneoplastic syndrome. So that little reinforcement can be done here along with this. Anyway, this teach that
First
can.
SLO, first SLO has that etiology of Cushing's, madam.
Okay, etiology, yeah. So there, through case base, we can emphasize it is also can be
Yes,
seen as a
yes,
paraneoplasm. Okay. Thank
yes,
you.
yes, madam. Yes. So yes, that lung cancer and other causes of paraneoplastic syndrome are some other causes
Yeah.
besides,
So that has been.
the adrenal.
Yeah.
Thanks, madam. And the last competency, PA 32.9, dealing with adrenal neoplasms. The SLOs, the competency is to describe the etiology, pathogenesis, manifestations, lab and morphologic features of adrenal neoplasm. And the SLOs derived are to enumerate the etiology of adrenal neoplasms, to describe the pathogenesis and morphologic features of adrenal neoplasms, specifically pheochromocytoma, neuroblastoma, and the multiple endocrine neoplasia syndrome, to list the clinical manifestations of adrenal neoplasms and to list the lab features of adrenal neoplasms. We have deliberately kept out adrenal cortical carcinoma, as we felt this was more for a PG level. And so this is a knowledge domain topic, and teaching learning methods be one lecture followed by a DOAP session centered around a gross specimen, maybe of a pheochromocytoma, for example. Assessment methods would be MEQ, SAQ, MCQ, and viva voce. And vertical integration, if time permits, would be with human anatomy, physiology, general medicine, and general surgery. So 30 minutes of lecture followed by 30 minutes of DOAP session to end this. That's all for the SLOs. Then next we'll be going to summarize how much time we have allotted to all these 9 competencies. The next, we have, as mentioned, PA 32.1, there'll be one practical or DOAP session. PA 32.2, PA 32.3 have been merged into a small group discussion where there can be sharing and nesting. That will be 1 hour. PA 32.4 there'll be on diabetes mellitus. There'll be 2 lectures and 1 integrated teaching symposium. Total of 3.5 hours. PA 32.5 just SDL or handout. So that may or may not be taken within the time limit. If we give handout, no separate time would be required. PA 32.6, again there will be 1 lecture, and let all decide if should be kept along with exocrine pancreas lesion and not in endocrine pathology. If we all decide in which chapter to take this particular competency, I think it will be helpful for everybody. PA 32.7 and PA 32.8, small group discussion, SDL integration for 1 hour. This is similar to the one where we did a merge session with hypo and hypothyroidism. And finally, the last one is a combined lecture and DOAP of 1 hour. That is on adrenal neoplasms. So 2.5 hours lecture, small group discussion 2 hours, DOAP 1.5 hours, and SDL if required 1 hour at the most. Next we come to case-based discussions.
Barnik, Dr. Langer,
Yes, Yes, sir.
One
Yes.
add. In parathyroid, have you covered competency of hypothyroidism or hypoparathyroidism?
Hyperparathyroidism. That's what's mentioned by MCI, sir. Only hyperparathyroidism is mentioned.
Yeah, hypoparathyroidism I have seen there.
Oh, no. It's very rare, rare too. Okay. Next, we go on to the case-based discussions.
I just want to say,
So,
Dr. Barnik, to everyone,
yes,
what you have said, adrenal neoplasms, that neuroblastoma has to be emphasized, because there's one competence in pediatric where we have pediatric tumors, infancy and childhood tumors. So that becomes a part of that. And since it is childhood tumors, what happens? Kidney also you tend to take Wilms tumor. So all those tumors gets covered. So that particular competency in that pediatric and genetic diseases which we have gets covered. So we have
yeah.
to, I think so, emphasize rather than, of course you have said that neuroblastoma has to be taken, but then to some,
Yes,
it can be emphasized so that pediatric competencies is gets taken care. Okay.
sure,
Yeah.
sure, ma'am. Next, coming to the cases for the case-based discussions. The first case is of a 40-year-old lady presenting with swelling in the right lobe of thyroid, noticed 6 months back. It measured 3 centimeters in diameter with surrounding thyroid gland appearing unremarkable on USG. Thyroid profile was within normal limits. So the questions to be discussed would be, what is or are the probable diagnoses? How would one go ahead with reaching the diagnosis? And how would FNAC compare to biopsy in helping to reach a definitive diagnosis? Along with this, we can provide either a gross specimen or the picture of the cut surface of thyroid lobe showing a follicular neoplasm, and that can provide the trigger for this case-based discussion. Next, coming to case 2, a 33-year-old woman presenting with symptoms of anxiety, heat intolerance, resting tachycardia, excessive sweating, and staring look. She had a diffusely enlarged thyroid gland. So the questions to be discussed would be, what is the probable clinical diagnosis? What are the expected findings in the lab tests? And what are the typical findings on FNAC? If this is on a slightly higher level, we can leave this particular question on the FNAC. That could be a PG level question. So we can just deal with the first 2 questions in that case. Case 3. This is on hypothyroidism. We have kept 2 cases. One is a short one and one is a slightly longer one. Shorter, this case, first one is a 27-year-old woman presenting with cold intolerance, dry skin, constipation, menorrhagia, and repeated abortions. Her thyroid gland was diffusely enlarged. So what is the probable clinical diagnosis? What are the expected findings on blood biochemistry tests? FNAC will show which characteristic type of cell, what does it contain in its cytoplasm. So they mention Hurdle cell and that it contains mitochondria, and mention 2 complications of this condition. That is malignant transformation, etc. Next case is a slightly longer one. 46-year-old woman who presented with complaints of tiredness and difficulty in concentration for past 1 year. She attributed the symptoms to stress at work. She had gained weight over the last year, and despite warm weather, she felt chilled without a sweater. Family history was significant for hypothyroidism in her mother and older sister. On examination, she had a pulse of 58 beats per minute and a blood pressure of 138 by 88 millimeter of mercury. Examination of her neck disclosed a small thyroid gland with an enlarged lobes on both sides and a firm bosselated texture. Serum taken at this time demonstrated a total of total T4 of 7 microgram per DL and TSH of 22 micro unit international unit per ml. Anti-thyroglobulin antibody and anti-macrosomal antibody were positive. Hello. Patient underwent surgery and the macroscopic section slides were given. Next. So the clinical picture along with the microscopic sections of the thyroid thyroidectomy specimen are provided. So the questions to be discussed would be: what is your clinical diagnosis? What is the suggested etiology of this condition? What are the other conditions that can be associated with this disorder? Mention the gross appearance of the condition. What are the microscopic features which are seen in this picture? And mention the lab findings of this condition. Finally, name two malignancies that can be associated with this disorder. So this is we finished with a thyroid. Next, we come into case on diabetes mellitus. Case 4, a 14-year-old boy presents to the ER with altered sensorium, fruity odor on his breath, and high level of urine sugar measured by dipstick. So the questions to be discussed are: what is the probable clinical diagnosis, and what gives the fruity odor to his breath? How are these substances produced? What are the diagnostic criteria given by WHO for this disease? Mention the 3 long-term complications of this disease, and discuss the morphology of the organ which is primarily affected in this disease. So picture of the dipstick is given alongside to aid the student. So this is a case of diabetic ketoacidosis, and we discuss it twice. Next, case 5. A 38-year-old man presented with recurrent urinary stones, USG abdomen showing features of nephrocalcinosis. Multiple lytic lesions are seen on X-ray of both lower limbs. So what is the probable clinical diagnosis? What are the expected findings in blood biochemistry? This picture of nephrocalcinosis is, on USG is shown. This is a case of metastatic calcification due to hyperparathyroidism, and whatever relevant findings would be there on biochemistry would be discussed. Next case. A 50-year-old man presented with features of obstructive jaundice. CT abdomen showed a 2.5 centimeter diameter irregular mass in the head of pancreas, and the CT images are shown alongside. What is the probable clinical diagnosis? How do you approach the case for a diagnosis? And comment on the prognosis in such a case. That's all for case 6. This is a pancreatic case of pancreatic cancer in the head of pancreas. Case 7. Next, a 35-year-old lady presented with excessive tiredness, orthostatic hypotension, and patchy pigmentation of the skin over the last 1 year. The questions to be discussed are: what is the probable clinical diagnosis? What are the 3 main causes of this condition? With which genetic conditions is this condition associated? So this is a case of and so it will be discussed in this particular fashion. We can add any number of other questions, biochemical alterations. We can discuss about other features, other causes So, okay, case 8. A 30-year-old lady having history of rheumatoid arthritis under treatment, presented with round face, abdominal stria, increased body hair, and irregular menstruation. What is the probable clinical diagnosis? What are the complications arising out of this condition? So this is a case of Cushing syndrome, and we have limited this to 2 questions, but other questions can also be added. That is, what are the other hormonal changes? What are the other related? That is, you can have hyperglycemia in this case related with that. The biochemical alterations, those can also be discussed along with this. Also, lowered immunity, etc., can also be discussed. Case 9. A 45-year-old man presented with right flank fullness with paroxysmal hypertension and orthostatic hypotension and anxiety attacks. What is the probable clinical diagnosis? What investigations need to be carried out to reach a diagnosis? With which genetic conditions is this lesion associated? So this is a case of a pheochromocytoma, and it can be discussed even further if required. That is, what are the various biochemical alterations that can be seen, etc. We can also replace this with a neuroblastoma or some other adrenal tumor too, if need be. Next, coming to the MCQs that are there for this particular chapter. So first is, which of the following is true of papillary thyroid carcinoma? The the cell nucleus shows often any appearance. Image is shown alongside. B, the least common type of thyroid carcinoma. C, the type of thyroid carcinoma with the worst prognosis. D, occurs in patients with MEN2 syndrome. And E, spread by hematogenous route. The answer obviously is A. And the rationale behind it is discussed in the next slide. So we can go to the next MCQ, which is the most common cause of hypothyroidism in an underdeveloped country. The choices are A, Graves' disease, B, Hashimoto's thyroiditis, C, de Quervain's thyroiditis, D, iodine deficiency, E, pituitary dysfunction. And the answer in this case would be D, iodine deficiency. The rationale for the answer and is given, and why the others are not applicable, that also is discussed. Question number 3. All of the following features are true about Cushing syndrome, except the choices are obesity, buffalo hump, moon faces, hyperpigmented skin, and glucose intolerance. So the right answer would be D, which is seen in Addison's disease and not Cushing syndrome. Next, question number 4. Which of the following is true regarding multiple endocrine neoplasia 1 syndrome? The choices are all patients develop medullary thyroid carcinoma, and many patients develop parathyroid hyperplasia, involves the red gene abnormality. A few patients may have a marfanoid habitus feature, and E involves the proto-oncogene P53 abnormality. The answer is B. And the it is discussed. The rationale behind the answer, the correct choice is discussed. Next question is question number 5, which is true about pheochromocytoma. This choices are mostly occurs in extraadrenal site, B, an aggressive malignant tumor, C, causes hypertension, D, derived from follicular cells. And the answer is C. The rationale behind the answer is also discussed. Next slide. Next question. Question number 6. Your sister is complaining that she is always tired in spite of getting enough sleep. You notice that she looks pale, and when you feel her pulse, it is quite slow. She also mentions that she can't withstand the cold these days. What 2 lab tests would be most helpful in diagnosing her condition? A, FSH and LH levels, B, free T4 and TSH levels, C, calcium phosphate and parathyroid hormone levels, D, insulin-like growth factor and prolactin levels, E, cortisol and ACTH levels. And the correct answer would be B, because this is a case of hypothyroidism. So the rationale is discussed in these 2 slides. Next, please. That's I think all. Next, I believe, yeah, there's one more. Okay. 47-year-old presented with a lump in her neck since 2 years. Her physician palpates a form nodule about 2 centimeter in size in the left of midline in the region of the thyroid gland. USG shows iso to hypoechoic nodule of 2 by 2 centimeter. By scintigraphic scanning, this nodule appears hot with normal activity in the surrounding normally sized thyroid gland. Which of the following is the most likely diagnosis? The choices are A, toxic nodular goiter, B, multinodular goiter, C, papillary carcinoma, C, D, follicular adenoma. And the correct answer is D. The image provided is of the scintigraphic scanning, as radionuclide imaging. The rationale for this answer is discussed in the following slide. And that's all for this set of MCQs. I'd like to thank Dr. Tamil Selvi for helping me out with the MCQs and also providing suggestions for the SLOs and discussions, case for discussions too. So it's been a good team effort with her. And I would like to thank Dr. Bedi and Dr. Vinay Shah for providing me this opportunity to present the SLOs of this endocrine pathology. If any questions are still remaining, please, I'd like to have them.
Any questions? Dr. Bedi sir, anyone wants to ask question?
I don't.
Doctor.
Yes. I don't see any hands.
Hands, okay.
This is a very I mean, you have gone into a lot of detail, even using the radiological aspects. And this is one topic which is quite often we generally ignore.
Right, sir. Actually, this topic involves a lot of clinical correlation from integration with, in fact, even MCI hasn't mentioned radiology as a part of the vertical integration, but I believe that also can be included if time permits, and the radiology faculty also are agreeable.
At least basics of radiology should be there. I think
Right, sir.
the patients who come to us, they generally carry some radiological report with them, which we read while we're making the diagnosis.
Right, sir.
Yes, Dr. Thamil Selvi.
Yes, sir. Sir, I have prepared. You wanted to know the endocrine, so I have prepared and given to him, sir, with the radiological, everything they must know like that.
Yes.
Yeah. I have
Thank you,
prepared some
madam.
more
Thank
that MCQs, everything, sir, to put it in present in the forum like that. I went into the image and everything I put it. Hello.
Thank you.
Hello.
Yes, sir.
Madam,
Anybody else would like?
Yes, sir. Yes, ma'am. Yes, ma'am.
It was very excellent, madam. It was really nicely put, very excellent. It actually, I felt endocrine pathology has a lot of scope for clinical, as he said, clinical correlation, scope for all case-based learning.
Yeah.
With all the
Because, ma'am,
tutorial
some of the areas we never
incorporated.
touches, ma'am.
Actually,
Some
we
of
don't
the
touch, and
areas
it is
we never
important.
touches.
Touch it,
So
yeah.
based on that, I thought I will give for a case-based learning or something, MCQs like that. Remaining only 3 lectures only usually will take, ma'am. Remaining all we can give it as a small group teaching, a small group teaching. Yeah, SDL like that.
Yes,
Self-directed
it
learning
will
like that
be.
we have to do, sir.
We can reduce the number of lectures out here, even though there are 9 competencies. We can make do with just 2.5 hours lecture, and the rest can be done on small group discussion and
diabetes
SBL.
mellitus we are covering in symposia type or seminar type, then automatically we can cut down the lectures and rest all as in small group teaching. Each case ka hypo, hyper of adrenal gland, this can be discussed in case based and cover the whole endocrine. It will be very excellent. Yes, very nicely
Ma'am,
covered, madam.
I have given
and
also
Dr.
for
Barnik.
integration, ma'am. Hello, ma'am.
Hello. Yes,
hello,
ma'am.
Ma'am,
Hello,
I have
madam.
given for integration also, like nesting. The share also I told him to put it. Thyroid and also diabetes.
Yes, he put it.
I've given
Dr.
him
Barnik.
to.
Yes, sir. Yes, sir.
Dr. Barnik, heartiest
yes,
congratulations.
Thank you, sir.
Number one, your slides were very good. Slides, color combinations, everything was very good. How much time you have taken for preparation? How much time you have taken for preparation?
Actually, both of us, myself and Dr. Thamil Selvi, have been doing this for the last 2 weeks, off and on, and ultimately.
Sir,
Good.
Sir, I took 3 days to prepare a case-based learning, sir. 3 days took a half a day like that. Hello.
Excellent efforts, and we must continue like that only.
Thank you, sir. Thank you, sir.
Thank you, sir. Thank you, sir. Thank you very much, sir.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you, everybody.
We will be having
for your
another
kind
session
attention.
tomorrow. Dr. Vinayak, we have a session tomorrow. Yes.
Yes, sir. We have tomorrow at that is 11th, that is Saturday at 1 p.m. SLOs in CNS, Central Nervous System, by Dr. Prasad. Dr. Prasad, are you there?
Ma'am?
Yes, ma'am. Yes, ma'am.
Hello, ma'am. If possible, can you give it on another day, ma'am? Because tomorrow also some topic on conferences going on.
Yeah.
People will be joining in that. Whether it is possible to make you to do that? Because
yes, madam,
many of the Tamil Nadu people, Tamil Nadu and Pondicherry chapter is going on. So people will be joining that. We cannot even today also so many programs, ma'am. So I could not join in time with you.
At 2 p.m. also there is something, I think so today also, madam.
It is going. It is starting program today.
It is going on. Yeah, it is just starting.
Madam, my humble request, ma'am. Is there any possible?
Madam, I was just suggesting, Dr. Vedikar also we have discussed, was wondering, madam, there are just 4 competence in CNS, 4 or 3 or 4, madam.
Yes,
so can we finish,
I know.
like today it went on very smoothly. So, madam, tomorrow by the TAPCON, I saw it is 12:45. There is a break from 12:45 to 1:30. So during that time, we can just finish off our 4 SLOs, madam. That will be good. Because Dr. Prasad sir committed to taking it tomorrow. Then we don't know about his availability about next time.
Okay, ma'am. Okay, ma'am. Even myself also half prepared, as you say. Along with the CNS group, I was preparing. I was posting also, not posting.
So there, if you all don't mind, madam, we can try to join 10 minutes early, like 12:45. Dr. PD sir will send a link around 12:45. We'll just join. Try to finish by 1:30. Then we can go back to our TAPCON.
Okay. Okay, ma'am. Thank you. Thank you.
Sir,
Thanks
what do you say, sir? Thank you, ma'am. Thank you.
Yes.
Dr. Bedi, sir, what do you say, sir?
Yes, yes. We'll start at 1 and finish it by 1:30.
Okay, sir.
Yes. I'll be sending the link in 15 minutes.
Okay.
Okay, sir. Okay, sir.
Okay, sir. Thank you, sir.
Thank you, sir, so much. Thank you, all of you. Thank you, Barney. Did a very good job.
Thank you. Thank you. Thank you, Dr. Vinay. Thank you, Dr. Bedi.